Very good evening to all of you. I welcome all of you on behalf of Department of Psychiatry, Diva Patil Medical College, Navi Mumbai, for this very innovative PG Psychiatry Knowledge Series. The Department of Psychiatry, Dr. Diva Patil School of Medicine, Navi Mumbai, has always attempted to pursue academic excellence. In that vein, we started a PG lecture series for postgraduate students of psychiatry from all over Mumbai and its periphery in 2015 under the guidance of our professor, Dr. Rashmin Cholra sir. We have another dimension to do it as of now. We present the PG Psychiatry video lecture series as an extension of it. This lecture series helps us and PGs all over the India and all over the world to variety of experts well beyond their backyards from all across the world. We hope this helps PGs, psychiatrists alike from all across the country. We continue to strive to make further advances in our teaching endeavors and make this and take it ahead and make it larger and bigger. Today's topic is brain networks in psychiatry by speaker Dr. Nachiketa Desai, consultant psychiatrist Navsari, and I welcome on behalf of Department of Psychiatry, Dr. Khyati Mehtalia, consultant psychiatrist from Ahmedabad. Next slide, please. A brief about today's moderator, Dr. Khyati Mehtalia, owner of Sakhi Women's Mental Health and Child Guidance Clinic at Ahmedabad. She was an honorary state secretary of Gujarat State Branch between 2025 to 2027, executive committee member of Western Zonal Branch of Indian Psychiatric Society 2024 to 2027, co-chairperson School Mental Health and
I
Subcommittee
think
of.
you can skip all that.
Okay, thank you, ma'am. And she has multiple presentations and papers, chapters to her credit. I welcome you, ma'am, on behalf of Dr. Diva Patil School of Medicine, Navi Mumbai, and I hand over the proceedings to you for the further session.
Thank you so much. Yeah. So, on behalf of D.Y. Patil University, I welcome all of the PJs for this very interesting session on brain networks. Now, this has always been a complex topic which some of the PJs like very much and some of them hate. This was what used to be during our times. Talking about that, we are having Dr. Nachiketa Desai, who has completed his DPM in 2015 from Civil Hospital and BJ Medical College, Ahmedabad. He is a visiting psychiatrist at various hospitals in Navsari, Gujarat, etc. His main areas of interest are personality, neurobiology of psychiatric disorders and its treatment modalities. He aims for better understanding of neuroscience of psychiatry and how it can be translated from bench to bedside. So this is what is written in his CV. But what I would like to tell about him, that he is a person with very precise knowledge, and he would like make the points very clear, is a very logical and
So you met?
hello?
Okay, just wait.
Yeah. Shall I continue or?
Hello, yes, ma'am, please.
Yeah. So a man of precision, I would say perfection. You discuss something with him and you'll come to know like there's a reservoir of knowledge within him. So with that, I welcome Dr. Nachiketa Desai.
Thank you, ma'am, for the kind words. Am I audible?
Yes,
Yes.
you are.
Yeah, so good evening, everyone. Today's topic is brain networks in psychiatry. So it's a subject of a whole book or even series of books. So rather than going into individual details, I would like to present something that can give you a approach and how to evaluate various articles, how to interpret findings. For that, not only us, for centuries, different scholars, academics, clinicians have tried to look at brain functions and try to localize them into various brain parts. Oldest one being phrenology, where different brain areas were supposed to be correlated with different functions. But then we all know that it was not true, and it was more closer to, let's say, astrology, I would say. So, but then it was a proto science or even early infantile science. Main significant advancement came with Brodmann, who divided brain cortex into 52 distinct regions based on the cytoarchitecture. So this is where most of the UG neurology teaching still stays, and a significant portion of UG neurology teaching also stays. And to some extent, our psychiatric literature also mentions these areas frequently. The clinical paradigm was classical behavioral neurology, focusing on these different areas and different functions being mapped onto them. We still talk about Broca's aphasia, Wernicke's aphasia. However, while structurally accurate, it could not explain the network level disturbances that we see in psychiatric disorders. So, as of now, it has slightly more clinical application in neurology than psychiatry, but we still should be aware of that for so-called organic psychiatric disorders. So overall, the things evolved from phrenology to Brodmann areas to then lobe functions, frontal lobe function, parietal lobe function, and so on. And now we talk about connectomics. But then when we talk of connectomics, it is not just fMRIs. It first starts with structural connectivity. So what exactly that means? All the neurons structurally connected to each other. How? Via cables. What are those cables? The axons. And they form different white matter tracts. And that is the structural connectivity. And it is usually visualized with the help of diffusion tensor imaging. There is a key metric called fractional anisotropy. So basically what DTI does is it measures movement of water molecules, and think of it like a highway and cars are going. If they are going in very streamlined manner, one behind other, no divergence or no sideway movements, then it is more of uh, isotropic kind of movement, whereas the anisotropy means there is a deviation. It's not going in streamlined manner. So how is it relevant in DTI? Because most of the axons are myelinated and the water molecules are supposed to be along those preformed channels. If the myelin integrity is disturbed, then you would see reduced FA and there is more diffusion laterally. And there are even other measures apart from fractional anisotropy, mean diffusion, and other things. There are various bundles defined into DTI, but some of the most common ones color coded here are this purple one, arcuate fasciculars, superior longitudinal fasciculars, uncinate fasciculars, and so on. All these white matter tracts do have relevance in psychiatry. They are computed and 3D models are generated from DTI data. And that comprehensive structural map or database of that particular brain has been extensively studied in psychiatric disorders. However, somehow they get relatively less limelight in our traditional textbooks. There are some replicated findings as well, but somehow we are still thinking of psychiatric disorders as non-organic. This is one of the example how that DTI looks. This is the case of schizophrenia versus healthy control, and these red areas are the differences shown. And there are multiple such articles available online. They are basically statistical models and calculated differently. I am not going into individual details as of now, just a broad overview. But people have also tried to move away from traditional DSM and ICD categories due to their limitations. First and foremost being that they are symptom-based diagnosis rather than pathology-based diagnosis. So something like ARDO criteria and other transdiagnostic approaches try to focus on more biologically homogeneous groups, and so they started with each individual symptoms. For example, psychomotor retardation in depression most commonly, but other disorders also. And there is actual change in structural integrity of the tracts, which are well correlated with psychomotor slowing. So it is not just a subjective feeling, it is actual physical degradation of motor execution pathways. And the findings are replicated. One of the replicated finding is reduced fractional anisotropy value in anterior limb of internal capsule, dorsolateral prefrontal cortex, premotor supplementary motor cortex, parietal cortex, and cingulum. Sometimes these changes even persist after treatment. So they may serve as a marker. Similarly, executive dysfunction, we know that prefrontal frontal areas are primarily associated with executive function in terms of lobar functions. And the primary tract that connects those areas to other area of brain, for example, parietal and temporal, is superior longitudinal fasciculus, as we saw in that color-coded image. Reduced FA in a particular segment of SLF has been seen in schizophrenia compared to other healthy controls or ADHD people or bipolar group. And the higher FA in another segment was seen to be associated with higher manic hostility score on BPRS. So it does have some diagnostic value in some sense. Positive relationships between FA and executive function is also seen. So what it means is higher FA indicates better executive function, reduced FA indicates poor executive function or executive dysfunction. Similarly, for emotional regulation, we look at limbic tracts, particularly the uncinate fasciculus, this purple one, that connects entorhinal cortex, perirhinal cortex, amygdala, and neighboring structures to orbitofrontal cortex. Now, just a bit of context, orbitofrontal cortex is supposed to be a stop signal or safety signal kind of thing, and the dysfunction is associated with OCD also, but it also has role with emotional regulation. So disturbance of this particular fasciculus is seen to be associated with limbic hyperreactivity because now amygdala and nearby structure have lost that frontal inhibition, and it is seen to be associated with emotional lability. So this is how we look at structural, and it has been being looked at for last 30 years or so. However, at times it is still not adequate, and we see functional connectivity, which is the current vogue word, fMRI and other related networks. So what is functional connectivity? What happens is in fMRI, they would look at bold signals, blood oxygen level dependent signals that indicate in a way metabolic activity of different areas. And during that resting state fMRI, when person is doing nothing, just idling, at that time, different areas light up differently. Some areas light up together, some areas light up reciprocally. All those statistical associations ultimately form functional connectivity or functional networks. So the divergence between functional and structural is functional connections can exist without direct structural connections, and there have been different explanation of micro, meso, and macro scale networks, but current area of interest in psychiatry is those functional networks because structurally it provided relatively non-specific data, although highly replicated. So what is functional connectivity? If we just look at it broadly, it is basically statistical association of two areas of activity. And in a way, you can consider it as a synchronization of neural activity in those two areas measured by Bolt signaling as discussed. And the region with synchronous low frequency Bolt fluctuation are supposed to be functionally coupled. This is also called ALLFF method, associated low frequency fluctuations. And this graph shows This particular graph with different lines is ranging from -1 to -0.5 all over to +1. That is the strength of association between those areas, like a regression coefficient. There are various terms that are relevant in discussing functional connectomics. Nodes and edges. Now, the thing with functional connectomics is they are not actual physical tracks. So what happens is these are different hubs and nodes. What are they? They are the regions of activity. Hubs are big regions with more activities. Nodes are relatively smaller regions with less connections. And then the statistical associations are shown as these edges, that this area and this area is simultaneously activated or synchronized. Various nodes and edges together make a huge mesh network, and of that, different parts are described differently. One important area is small world. So basically local segregation of the small modular things, and then global integration of such small modules. Of them, some areas are such that multiple connections pass through and they light up in correlation with or in synchronization with multiple other areas. So these are called strong hubs, and cluster of such hubs is called rich club network or rich club hubs. And these various edges and statistical associations and various concepts are assessed using various mathematical tools like path length, that edge, and how many minimum steps are required to traverse from one node to other. What is the clustering coefficient? What is global efficiency? That will indirectly reflect about small world and large world organizations. And the rich clubs or the hubs are important because any damage to this area causes widespread dysfunctions, because they are the interconnected backbone of whole network. And so high degree hubs are more interconnected with each other than by chance. And because of that, they may form part of various different networks rather than just being isolated or member of only one network. So they can be considered as sort of routers where multiple things pass, or a railway junction where different paths and tracks meet and diverge. Coming to networks, so this is the most popular area or most in vogue area, the triple network model. We know of the three networks: default mode network, alliance network, and central executive network. In 2011-ish, Vinod Menon gave this model for first time. And then we had some sort of organization of functional findings that we see in functional connectomic studies. One of the first network was default mode network, as highlighted in red on the figure. It connects medial prefrontal cortex, posterior cingulate cortex, precuneus, and primarily it is the idling function. So when the person is at rest, not thinking about any particular thing or focusing on one particular task, these areas light up. And at the time, most of the people are either thinking about themselves, so self-referential thoughts, autobiographic memory, spontaneous mind wandering. These are the functions or activities that correlate with this particular bold pattern or fMRI pattern. It has been found to be disturbed in almost all disorders. So the context for triple network model is it is just a model. All psychiatric disorders will have some or the other form of disturbances in these networks. One of the replicated finding is DMN hyperconnectivity has been found to be associated with depressive ruminations, because person is constantly thinking about that same thing. Other area is Alliance network. So what Alliance network does is it basically acts kind of as a switch between default mode network and central executive network. The key nodes in this network are anterior insula and dorsal anterior cingulate cortex. It also filters irrelevant information, and if there is a salient event or stimulus, insula generates the signals that disengages the DMN and recruits the executive networks. Sometimes they are also called task positive networks because once Salience network shifts the pattern towards central executive network, the attention is drawn towards that salient event, then brain starts thinking about doing something about that. So aberrant alliance would lead to or inappropriate activation of CN. The attention will be drawn to abnormal stimuli or non-related or trivial stimuli. So that can be form a basis of delusions, hallucinations, even disorganizations. Central Executive Network is our primarily executive function related network. So it will largely cover dorsal lateral prefrontal cortex and posterior parietal cortex. Obviously, it is engaged during task positive networks, demanding tasks requiring working memory, planning, problem solving, goal directed behaviors. The CN hypoconnectivity. So that would basically mean executive dysfunction. So all disorganized thinking, poor working memory, negative symptoms observed in schizophrenia are associated with CN hypoactivity. Thus, three main networks as described by Menon work together. Default mode network is primarily inwardly directed, thinking about self, autobiographical memory, etc. when idling. However, when there is a stimulus and we need to pay attention, Salience network reduces DMN or disengages it and focus is drawn to particular activity and task positive networks are online. So there is a reciprocal relationship which is called anticorrelation between DMN and CEN. Now in many of the psychiatric disorders, this anticorrelation is lost. So what would happen is you are trying to do a task, goal directed activity, CEN should be active and DMN should be suppressed, but that suppression is not there. So you will have constant back running thoughts which are distracting or even intrusive in nature. If the Salience network is disturbed, then we see different perceptual and interpretational errors mostly associated with psychosis. But it can also be seen in anxiety as we will see in upcoming slides. So dysregulation of this tripartite system was supposed to be the common language or a template to describe various disorders. But then people found that the functional connectomics or the functional connectivity is not restricted to these three areas. There are other areas also that functionally lined up and correlated with each other. Some of the common ones are visual network, mainly assess vision and related functions. There is auditory network, again, speech and hearing related things, somatomotor, movement, planning, those things. So this is the examples. If you can see here, primary visual, secondary visual, somatomotor, auditory, and then they are classified into various dorsal and ventral attention networks, cinguloopercular networks, frontoparietal networks. There are many more, but the point being that we are not limited to three DMN, CN, and SN. There are multiple networks. And again, to reiterate, these are statistical associations, areas lighting up together or reciprocally. And those are found across the species, but of all, some of them are seen in most species like DMN and Salience network are nearly universal, but there are other networks also. Now, how would we look psychopathology as network dysfunction? So some of the examples are based on DSM criteria and categories because at the end of the day, we want to recruit patients into studies and most of the studies still follow DSM and ICD. In schizophrenia, it is disconnectivity. Now the important part is DYS. There is a difference between DYS disconnectivity and DIS disconnectivity. DIS would mean areas not connected at all. DYS is abnormal connectivity. So what kind of things are seen? Frontotemporal uncoupling, that statistical coupling that was seen is reduced. Poor synchronization between prefrontal and sensory processing areas. DMN intrusion is also seen. So intrusive thoughts and internal dialogues tend to blend with external reality, appearing as hallucination. Thalamic deficits are also seen that failure of thalamic getting to weed out irrelevant stimuli also lead to various forms of hallucinations where the environmental trivial stimuli should have been filtered out but are perceived as significant. Again, that is also related to SN dysfunction. In depression, the rumination part, as we saw already, when idling person is thinking about self, so hyperactivity of DMN. There is overactive self-focus, so pathological hyperconnectivity of DMN with negative memories and sometimes insular hyperactivity also. Cognitive executive deficits are noted as hypoactivity of CEN, and there is specific subcortical reward blunting also seen via uncoupling of reward pathways and PFC. This is one of the markers of anhedonia that we'll discuss a bit more later. In case of bipolar, again frontal limbic coupling. Now this limbic part is gone, so emotional or emotion control networks are disturbed. So in structural terms, we saw uncinate fasciculus, almost parallel to that. And many a times these fluctuations are dynamic, changes with mood state, and fluctuate more than normal. Striatal hyperactivity is also seen, which is associated with a higher reward sensitivity and higher pleasure-seeking goal-directed behaviors of manic or hypomanic states. So the structural and functional connections normally allowing prefrontal areas to control subcortical emotional activity signals and activity, they become weak. So unfiltered and undampened emotional activity and reactivity leads to various behaviors that are seen in mania and hypomania as impulsivity. In anxiety and PTSD, as we briefly highlighted previously, Salience network is disturbed. So what would happen is any trivial stimulus, the Salience network draws brain's attention towards that, engages CN, and normal small trivial stimulus is now perceived as threatening, dangerous, generating amygdala overactivity and anxiety symptoms. Fear extinction is impaired. Now this fear extinction part, connection between prefrontal and amygdala. This is that again OFC to amygdala connection primarily or VMPFC to amygdala connection. And again disrupted interaction between memory structures and DMN triggers those flashbacks. Loss of anticorrelation as discussed before means that even while trying to engage in some activity, those flashbacks intervene intrusively. In case of ADHD, there have been some studies, but again, impaired anticorrelation. One wants to focus on a task, but DMN is not getting suppressed. It is still staying active. Salience failure, so distractibility. Brain doesn't know what to filter out. Striatal dopaminergic deficits leading to impaired reward network coordination. So this is more related to so-called dopamine deficiency syndrome, but maybe a descriptional link between ADHD and addiction or substance use and impulsivity we see. In autism, so there are multiple studies. Again, autism and ADHD, they are biologically heterogeneous groups. So it is hard to replicate findings, but what they have seen is local hyperconnectivity, those small world areas, and long range hypoconnectivity. So small areas are hyperactive, but they are not coordinating with each other very well. And when the social reasoning and language and other areas are affected and have weak function, theory of mind deficit emerge. But then again, theory of mind is again a bit of debated topic. Mirror neurons nowadays are not very strongly consensus based opinion. So to summarize some of the findings, in depression, something like hyperconnected DMN suggesting rumination, hypoconnected CEN causing the executive dysfunction, SN hyperresponsivity, so person may fail to attend to some stimulus. Similarly, schizophrenia across board disturbances ADHD again, as we talked about. So this is how the tripartite or three network model was supposed to help us understand various psychiatric presentations. However, moving beyond the traditional DSM ICD, now the focus is shifting more towards symptoms. For example, why anhedonia? Reward circuit disturbance. This was the part we were mentioning earlier. Reward circuit disturbances will be associated with anhedonia, and one of them being the steatocortical deficits. So, particular circuit of intrinsic functional connectivity pattern involving pregenual and subgenual ACC, supplementary motor area, and supramarginal gyrus were associated specifically with anhedonia severity. However, even in functional connectivity, we are now realizing the limitation. So first there was phrenology totally discarded. Then there was Brodmann and Luber function, which are still relevant to some extent, but did not provide any conclusive stamping diagnosis. So then came structural connectivity. Then came functional connectivity. This functional connectivity was primarily fMRI, metabolic activity of various brain regions, averaged across 10-15 minutes, but it still does not give us full picture and fails to capture many significant phenomena. So what are the criticisms of static functional connectivity? The averaging effect, rather than going it minute by minute, it's an average of 15 minutes. So it blurs distinct states. For example, somebody had some particular state for very short period of time. For example, here they have mentioned 10-second auditory hallucination. Now across 15-minute averaging, it will totally get lost. Signal is missed out. Another flawed assumption is stationarity. These networks are not stationary. Although there is statistical connection, it fluctuates a lot. So the spatial reductionism of three networks does not look at sensory networks primarily, as we saw earlier, beyond triple network. It omits lot of limbic data, thalamic data, and so a significant amount of data is not considered in traditional FC models. Cortical bias is also seen, as we mentioned. Thalamic activity is largely missed in discussions of all those areas. And so getting functions and other related things are not taken into account in normal discussions. However, they are equally important. And cerebellum, as always, neglected part. So initially it was that it is purely motor focused, but no. There is a concept called motor behavioral analog. So it tries to say that there is a parallel between a motor output or motor program and behavior. That is how we see stick and compulsion association and those kind of things. Another clinically relevant example may be how certain people with ADHD are more prone to haphazard behaviors, hurrying, and then losing coordination. All those things correlate with frontal function. That stationarity assumption, again, we need, 10 to 15-minute window is too large to recognize second level activities or real time monitoring, I would say. So we have to move towards networks, those that can capture those small sub-minute or second level fluctuations and not over rely on triple network model, because as we saw in earlier findings, the findings seem similar across all disorders. So how do we interpret them? They won't be able to serve as proper clinical biomarkers. And one of the major reason is that again, DSM ICD criteria are symptom based rather than biology based. So that heterogeneity will dilute the results. And so we don't understand general systems. So rather than looking at it holistically, it would just isolated few networks. Even if we go beyond triple network model, that doesn't capture the whole picture adequately. So what can be done? So now what people are trying to do is, even in functional connectivity, they are not looking at those yellow, green, blue blobs as a static thing. They are seen more as dynamic thing. The difference can be that of a static image versus an animated GIF or a video. However, that would require technological improvement and paradigm shifts. So what are the approaches possible? So now these are the areas how the data are captured and then modeled onto networks rather than looking at whole 15-minute average. We are now subdividing it into, let's say, minute level or 30-second level slices, and then looking at how those slices change. Now, this required very fast computing, but thankfully now we have faster and better computers. So then we can get some idea about various microstates, how they fluctuate over time, and there are different clinical matrices to measure those. And one of them being the dwell time, how much time is spent in one particular microstate. And there are various calculations. This is one of the example of sliding window correlation. And this is the thing. So the fluctuation. Now, again, two areas coupled together, the statistic correlation ranges from -1 to +1. And over time, that coupling or uncoupling fluctuates. So rather than static connection, even in DMN, let's say all those different regions, they are not constantly coupled or correlated. They fluctuate between correlated, anti-correlated as required. And when we have sliding window analysis and microstate observations, we can look at these kind of things. And for that unifying framework, one of the proposed framework is DISCO. This is by Giuseppe De Alteris, and it helps us provide a common language and how we can efficiently compute different data and discuss with each other. So in future, not just this, there are other approaches are also upcoming. Gradient-based studies and hierarchical collapse related issues, how there is loss of aggregate and why that internal external boundary gets blurred, particularly in psychosis. And with those microstates, we will have more data on continuous phenotypes rather than snapshots at few minutes apart or averaged out across. And then maybe we can also apply those diagnostic modalities to real-time monitoring of treatment. And then we can have personalized TMS and other observations, closed loop neuromodulations, etc. So in a nutshell, this was the bird's eye overview of how we should look at brain network. The take-home message would be, although we are looking at DMN, Salience network, and CEN as buzzwords, we need not forget the structural connectomics part, nor we stick to DMN and these things as very rigid and all powerful things. Otherwise, they would become next monoamine hypothesis. Now we know that serotonin, dopamine, and other monoamines, they are not sufficient to describe all various brain pathologies. Somewhat similar tendency is now seen with triple network model that anything DMN buzzword. Now let somebody would say, okay, DMN this, DMN that, this it means depression, and DMN that means no, it does not work like that. At max, we are looking at brain level constructs like executive dysfunction, processing speed, and correlation and correlation. And even there, we are moving beyond static functional connectivity into dynamic functional connectivity. Thank you.
Yeah. Thank you so much, Nachiket, for taking us through this fantastic journey of how our understanding of brain has evolved from phrenology and localization to connectivity and now to dynamic brain networks. What I particularly liked was the message was not remember this network. The message was understand how to look at the evidence. Because in psychiatry, uh, it is the brain is rarely about one region or pathway, and understanding the connections may be as important as understanding the individual parts. So let's have questions from the postgraduate students. Audience, any questions?
The questions will be posted in the chat. Uh,
haven't
The
found it.
audience, yeah. So audience won't be able to ac- ask them directly.
Okay, there are no questions.
We have one question.
There is a question. What about the RDOC model, HITOP model?
Yeah, so good question. So these are frameworks. So we are now into a bit of taxonomical territory rather than specifically our subject today. So what happened is because the DSM ICD classifications have been driven by symptomatology or semiology rather than underlying pathology, different frameworks have been proposed. One of them is research domain criteria or RDoC. Other is hierarchical model called HITOP. Now, what happened is RDoC was proposed as a way forward as a transdiagnostic framework so that we can look at psychiatric symptoms in more brain aligned manner, but then there were some limitation and it was seen to be more academic. So then the other group proposed a more clinically relevant model called high top. So you can think of them as bottom up versus top down approach. Now with that framework we can look at the functional connectomics data. So those are frameworks or lenses, whereas imaging and brain network things are basically tools to investigate various symptoms, and then those can be looked at through RDoC or HIDOC lens and interpreted accordingly. So yes, there are many studies. Even I think Thomas Insel few years back declared that they would now only provide in a way grants to models focusing on RDoC and not traditional ICD DSM. So that is there.
Yeah, one more question. Apart from neuroimaging, is there any other way to assess or evaluate DMN?
So that would actually depend on what we mean by DMN. If we look at it as functional connectivity, then primarily it is fMRI term in functional magnetic resonance imaging, that too primarily gold signaling related fMRIs. But those areas and those activities, they can definitely be measured through other modalities. One of the common approaches and promising approach is connecting that imaging data with electrical activity, for example, EEG or QEEG. And then QEEG provides very fast millisecond to second level temporal resolution, and MRI provides very millimeter level spatial resolution, and we can get the advantage of both. So there are hybrid models that look at same activity or same area as what is looked at through DMN, but whether we call it DMN or something different is one another question.
Another very interesting question is, how can we translate circuit level understanding into choosing medication treatment approach practically?
So this is one of the double-edged area, which was also the take-home message, that there are studies ongoing and have been done in regards to antidepressant response and antipsychotic response, and let's say late life depression and vascular depression area, and how certain deficits are well correlated with poor antidepressant response and those kind of things. But it won't be as simple as DMN this plus EN this equal to sertraline and DMN that plus Salance network that equal to olanzapine. So we have to keep in mind that we are not being overly reductionist with this functional connectomics.
That's great. So I suppose the questions aren't any more questions. So, Dr. Rashmin, shall we end it?
Sure. Thank you very much. Brilliant. Nachiketa is lucid and brilliant as usual. And thank you, Kathy, for moderating it very well. And we hope that everybody enjoyed it as much as we enjoyed bringing it to you. And I think the mark of a good speaker is the lucidity and the simplicity with which he has gone about the entire presentation. So truly remarkable. Thank you, Nachiketa. And we are going to pull you back time and again. And we are going to hopefully invite Kathy as well on our forum to share her thoughts with us from time to time. Thank you very much. And we look forward to seeing you at the next session. And thank you, Sun Pharma, for being a strong backbone for this program and being a chronic long-term supporter for us. And hopefully, we shall continue to enjoy your company in the future as well. Thank you all for being with us today. Thank you.